Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by your friends at Advisory Board. We would like to remind you that the chat feature is available, so feel free to send in your questions and comments throughout the presentation. We would love to hear from you. And with that, I will turn it over to today's speaker, Rachel Woods.
Hello, everyone, and welcome to the webinar. I know folks are still trickling in, but we have a lot to get through, and so I don't want to punish the punctual. My name is Rachel Woods. Most folks call me Ray. I am Vice President and National Spokesperson for Advisory Board. For those of you who don't know Advisory Board, we are a healthcare business research firm, which basically means that me and my company exist to try to help healthcare executives and help health leaders make better decisions, understand what's happening in the market, navigate an increasingly complex world, and hopefully move their businesses and their organizations forward. And that's starting to give you a bit of a teaser of where I'd like to take our time together today. Now, I have, of course, brought the research, the materials to advance this discussion, but I know that all of you are in this kind of interesting time in healthcare where we're at the beginning of a year. We are in an election year. We're setting our strategic plans. We're maybe already reevaluating what we set out to do in 2024. And across our time together, I want to tell you not just what I and what Advisory Board is advising executives on, but specifically what we are telling CEOs of health systems, of health plans, of life sciences companies, of pharmaceuticals, of manufacturing companies, what we are telling them they need to know in 2024, and why we believe that preparing for pretty seismic shifts in healthcare is going to be necessary for everyone, but in particular for the C-suite. As a reminder, if you have questions, comments, please go ahead and send them my way throughout our time. You are an important resource here as well. So let me tell you how we're going to use our time together today. First, I want to give you a little bit of a snapshot of the here and now, of literally where healthcare sits today, January 23rd, 2024, and why I'll characterize this moment as one of instability. Then I want to spend a little bit of time talking about how purchasers are reacting to that particular moment in healthcare and give you a sense of how we're seeing purchasers of all stripes, frankly, turn the screws on incumbents and legacy players in healthcare delivery. But the number one question that I get asked, especially I think in January, is what is the future of healthcare going to look like? What are the things that I need to have on my radar as a leader, as someone that works in healthcare business? When I talk about the future of healthcare, the question is the future of what? And today I want to talk about three major shifts that are happening in healthcare business. Frankly, these are shifts that have been happening for some time, but they are accelerating right now. They were really starting to accelerate in 2023, and now we've simply hit the gas. And I believe that those paradigm shifts are going to change where care is delivered, who and what is delivering that care, and frankly, what that care is and how we actually pay for it. So no small agenda for the hour that we have together. And I know I, in fact, was reminded this morning when I got a call from a healthcare executive that I work with frequently. And she said to me, you know, I'm starting to get a lot of questions about health policy. And I'm starting to get a lot of questions about how the political landscape will change healthcare in 2024. Because of course, we're now in an election year. And I'll be honest, that is something we'll talk about today. That is often precisely how I begin these conversations. But when I reflected on this moment, on where things stood in healthcare in January of 2024, I decided it was more important to kick us off in a different way and actually focus on patients, the patients that we either directly serve or intend to serve through our businesses and our products. And the truth is that today, patients are not okay. Some things are staying bad. Some things are merely just getting worse. But if I look at the heart of our business, what I see is rising behavioral health needs, rising maternal mortality, decreasing life expectancy, undetected cancers, missed prevention in part due to cost avoidance. And frankly, and I don't hear enough about this, I also see more workplace violence, more aggression coming from patients, coming from community members, and taking it out on the interior of the delivery system. That speaks to the frustration that our patients have with healthcare, and frankly, I think with life. So the patients, the people who are supposed to be at the core of our business, are not all right. And the patients are not all right because we are not all right. We are not all right. Now, there's a lot of ways that we could look at the report card of performance for healthcare, right? But I've chosen to look at two major areas of focus. On the left-hand side of the slide is quality, and on the right-hand side is spend. These are two of the biggest ways that our own performance is evaluated by purchasers, by policymakers, right? If I think about the fact that this is an election year. So let's look at quality, right? I already mentioned the state of patients that are getting worse. But if I look deeper, I see safety and adverse events are up. I already mentioned maternal mortality up. This last kind of data point here continues to shock me, and that is that 73% of American adults believe that the healthcare system is not meeting their needs. I'm going to say that again. 73% of American adults believe that the healthcare system is not meeting their needs, right? So we're not necessarily meeting this performance benchmark when it comes to quality, when it comes to safety, when it comes to outcomes. Now let's look on the other side of the slide. This is all about spend. I want everyone to put their blinders on and ignore that spike that is in the middle of that graph there. Obviously, that includes the federal funding for the COVID-19 emergency. But depending on who I talk to, when I show them this data, I get one of two reactions. Maybe you're a bit of an optimist and you go, well, it's relatively stable. At least it's not gotten dramatically worse. Pessimists in the group will go, wow, things have only ticked up despite all of the efforts that are happening in our industry to curb spend. Now, again, I could have picked many different metrics to evaluate our performance as a business, as an enterprise writ large. I picked quality and spend for a particular reason. In fact, I was having a conversation about the state of healthcare recently. And I got to about this point in the conversation, and I got some immediate pushback, which was, yeah, of course we're not talking about value-based care, kind of almost poking fun at me that I had saying that I had missed part of the conversation because I didn't name value-based care specifically. But I want to be clear from the start that when I look at our performance, when I look at quality and spend, those are absolutely the two key areas that we need to keep in mind when it comes to our performance on business model transformation, something that has been well underway for 1, 2, maybe 3 decades, depending on how you want to measure it. And all of this is happening here and now. And all of this is why purchasers are saying not good enough. Purchasers are looking at our performance on quality and spend and saying, seems like I need to step in and turn the screws. What's difficult is that, first of all purchasers are doing this. But second of all, they're doing it in different ways, and that increases the pressure and that instability on incumbents. So there are 4 that I can highlight for you now. They come across Medicaid, Medicare Advantage, pharmaceutical business, and the employer. That's actually one that I think is often left out from the conversation about purchasers. Medicaid is still in this state of whiplash, right? As we deal with the fallout of the redeterminations that were able to start last April with the ending of the public health emergency. Those redeterminations actually could start a few weeks before the official end of the PHE. And that has impacts on providers, on payers, certainly on patients, right? Particularly as we expect to see more public coverage coming out of the pandemic than we had in 2019. More public coverage means more spend, more focus on how can we uphold quality and hopefully curb, if not decrease cost. Medicare Advantage is the story of the moment. It's the story of the moment both because there is a lot of focus on the growth opportunity that comes with Medicare Advantage. But at the same time, this is a business that's, of course, being squeezed, right? The federal government is looking at performance across Medicare Advantage and is asking, is it doing what it set out to do? Maybe not. So we're going to make it more difficult to earn star ratings. We are going to introduce a rate cut for 2024, right? We are going to start to shift things to make it harder to succeed on the business model side of Medicare Advantage and hopefully get to that, again, higher quality curbed cost. You might think that 4.7 billion is a big number. How about almost $100 billion, right? Which is what the pharmaceutical business is looking, or what the federal government, I should say, is looking to save over the next 10 years when it comes to drug price negotiations. On the far right side here, the often undertold story, as I said, is the employer who is feeling more and more pressure to manage their own healthcare costs, more and more pressure to prove that they're providing reasonable health services for their employees, and is saying that their healthcare costs are unsustainable, right? A reason to focus on quality and on spend, in this case, in the context of benefits. These are just 4 examples that I could share. And I want to leave you with this slide. And before you start trying to pick apart all of the words that are on it, I actually just want you to focus on me for a second. The truth is, this slide is my and my team's best attempt at recreating that meme from It's Always Sunny in Philadelphia. You know, the one with all of the red string connecting. This goes to show that the pressure that purchasers, that policymakers are putting on different parts of business are going to affect everyone. They are going to trickle down to everyone. It is going to raise blood pressure and tensions for everyone. And when I say everyone, I mean life sciences and tech. I mean PBMs. I mean health plans of all sizes. I mean health systems, hospitals, medical groups, and I do mean patients. And so far, I've only talked about what's happening right now. So far, I've only talked about what's happening in this moment in healthcare. And if you are a healthcare leader, a healthcare executive, certainly if you're a CEO, you would be forgiven to say, that's enough. That is plenty on my plate to set my agenda for 2024, even to start thinking ahead to 2026, to 2032, to whatever it may be. But the truth is that a lot of the moves that we're seeing, a lot of the pressures that are coming from these purchasers are also part of bigger, larger trends that we've been tracking in healthcare. We can't just focus on the fire that's directly in front of us. The problems that this slide shows are directly in front of our nose. We have to think about the future of healthcare, which again brings me back to the number one question that I am asked, which is, what does the future of healthcare mean? When you say the future of healthcare, tell me what that future looks like. Now, so much is changing in our business. So much is accelerating in our business. But for the purposes of our time, I want to focus on, again, 3 areas that are rapidly changing. I want to talk about how delivery infrastructure is going to change, how care team rules are going to change, and how treatment economics are going to change. I want to orient you to what's happening in this slide here. So on the left-hand side, we have, frankly, the old world, right? This is how healthcare used to operate. When it comes to where care is delivered, who is delivering it, and how we pay for it, and frankly, even what it is, the old world is very hospital-centric, very physician-centric, with very little use of technology, and very, very procedure-focused. And that allowed us to create structures. How well they performed is a different story, that allow us to tinker with things like quality and cost. Again, our performance there clearly in question. But the truth is, the realities on the left are already realities of the past, right? And we've been moving away from hospital first, overextended generalist first, procedure first for some time. What's different is that in the last year, in the last several months, in the last several weeks, we've seen huge accelerants that push us to at least where we are today, but really start to tell us where the future outlook might go. Now, I am not here to peer into my crystal ball perfectly. I am also not here to tell you that that future outlook is good or bad. As you're listening to this conversation, I expect that you will have your own opinion on if that future outlook is good for patients, is good for you, is good for your business moving forward. What I am here to tell you is that that future outlook is absolutely possible. This is where the dominoes may fall, and not in that far or futuristic of a timeline. So if we're not going to be hospital first, where care is delivered is through ecosystems. When I say ecosystems, I mean vertically integrated delivery networks that have been growing and growing and growing for some time and have clearly overtaken kind of power, right, over traditional hospital and health system incumbents. So what does that mean for healthcare? Will be a question that we start to address today. We've moved away, or should be rapidly moving away, from the overextended, and I'll even say physician, as the central piece of care delivery. Because of the workforce crisis, because of the emergence of generative AI, we now will get to a place of technology-dependent, artificial intelligence-dependent care teams. And we'll talk about what that looks like, and frankly, the shiny objects that I want you to avoid and the practical realities that I want you to focus on. And last is probably the one that I personally am the most worried about, and what I'm not hearing enough about in the market. And that is that we are, and in many ways have already, moved away from treatment that is focused on procedures. There are novel breakthrough drugs that we now have at our disposal, some of which are changing lives, some of which are curing disease, some of which are intended for the masses, some of which are targeted at very niche populations and rare diseases, all of which are extraordinarily expensive, and all of which will require us to change the way that we finance care delivery, particularly in a world where our new metric for being able to access healthcare won't be, can I get in to see a doctor? Can I get in to have a procedure in a hospital? Instead, it will be, can I get access to one of these drugs, right? This is what I mean when I say the future of healthcare, and where I want to spend the rest of our time. Now, I want to start by talking about our first trend, which is in where care is being delivered. And I hope they're kind of nodding heads saying, yes, I understand that we've moved past this hospital first mentality. But if that's true, it's also true that plenty of different players have cropped up in the last couple of years, trying to fight for being the nucleus of power when it comes to healthcare delivery. And we're going to focus on ecosystems today. And I mean vertically integrated ecosystems here. The big names are ones on this slide that you'll recognize: UHG, CVS, Humana, Walgreens, Walmart, Amazon. Now, where I don't expect a lot more movement is what you see on the left-hand side here, right? There's just saturation in the market when it comes to insurance plus PBM. I don't expect a lot there. Where there will still be competition, although where time is, I will admit, is running out, is on community assets. And when I say that, I mean pharmacy, I mean retail clinics, I mean urgent care clinics, I mean physicians. We are still in an arms race over medical groups, whether it's primary care, certain specialties, home care, certainly a part of that, digital, certainly a part of that. Where do you not see a lot of competition, a lot of focus on when it comes to building an ecosystem for healthcare? There's a big one I haven't mentioned, and that's hospitals. Nobody basically wants to buy hospitals. Apparently, the only person who wants to buy hospitals is Mark Harrison, who, of course, last week, his VC firm, right, announced that they were going to be buying, that they had intended to buy, I should say, have intent to purchase Suma Health in Akron, Ohio, right? I did get a comment, I'll say back on the kind of outline of what we're going to be talking about today on drugs, on what care delivery could look like outside of those drugs. So note that I'll address that when we get into it. I will say that a lot of the investments that you see on this slide are in part to help organizations succeed in the current model of value-based care, which means dealing with high-risk populations, right? So if I look at convenient care is not about, can I get a flu shot quickly anymore? Convenient care is about how can I create simple, easy touch points for patients with chronic disease so that I can consistently see them, do care management, do medication adherence with them, right? There's a lot of focus on the silver tsunami and a lot of focus on senior care right now, and rightfully so. 10,000 baby boomers age into Medicare every day. It is an enormous burden and challenge on our own system. That does not mean that there are not organizations that are focused on the rising risk. It's not where the biggest pain point is right now. But you'll notice if you look at where people are buying and building assets, the same convenient care clinics, the same medical group infrastructure, the same pharmacy infrastructure, even to a certain extent, the home care infrastructure is going to help serve that high risk population as well as the rising risk population, which what I'm talking about means the wraparound support that is outside of the procedure or even the drug in that case. But I mentioned nobody is really focused on hospitals. It would be easy then to assume that all of these vertically integrated players are just trying to do the same thing. You'd be forgiven if that is your thought, but you'd also be incorrect. So I've got some examples of strategic goals for these ecosystem players here, right? We've got the cross-sell approach, which is, of course, come into CVS or Walgreens, get your convenient, get your kind of regular visit to deal with your CHF or your type 2 diabetes, and also buy shampoo. I'll take the money. Great. Wonderful. We've cross-sold our services. Amazon clearly wants you to get not just your drugs and your primary care from them, but also your streaming services, also your bananas and your, wedding present for your nephew and all of that from Amazon. We also see, and I already clued you into this, the focus on senior care value. If there's a population that health leaders are focused on right now, it is seniors. Part of that is, again, the population, the demographics, the numbers are just, you just can't ignore them when you think about the size of the population. And of course, when you think about the unmet needs of the silver tsunami, the big and perhaps hardest strategy you see here is basically to do it all, right? To be the complete ecosystem, enterprise. Platform is another buzzword that I hear a lot here, which really means to be the operator that can steer patients through every single part of the healthcare ecosystem for all of their needs. And I want you to notice immediately that these don't exist in the perfect boxes that they look like on this slide right now, right? Hopefully you caught on to the fact that, for example, CVS, sure, they're happy to cross-sell services, but they are very, very focused on senior value. UHG is focused on senior value and also trying to be the ecosystem of care. So these strategies don't necessarily exist in neat, perfect lines, but they do map back to those investments, those practical investments that those ecosystem players are making. The question that should be on your mind, if it's not, okay, where do health systems fit in this? And the truth is that even today, health systems they're in a very, very tough spot. I will be honest that over the last few weeks, maybe if I'm generous, the last few months, I've started to hear a bit of, an exhale from hospital leaders in particular who are saying, I can breathe again. Things aren't as painful as they were certainly in 2022 and in the start of 2023. But a lot of that kind of exhaling moment, frankly, has come out of the relentless focus, and I mean relentless focus, that health leaders have had on operations, I mean, they are through sheer grit have focused on length of stay and supply chain and workforce shortages. They focused on revenue cycle, they focused on throughput, and they're doing this by basically putting pedal to the floor and trying to work as hard as they can. And it is not a moment for health systems or hospitals to get complacent, particularly as many of the trends that you see on this slide march on. The workforce shortage and challenge continues. The outpatient shift continues and accelerates, both in terms of site of care and in terms of the services, or even the acuity of those services. So what are hospitals to do? Well, in many ways, they're pursuing lifelines. And I actually want to call these strategic lifelines, because what I don't mean here, for the majority of hospitals, I should say, I don't mean that there is a moment of desperation, but they are saying, I see the writing on the wall and I need to make the right strategic decision that may be a very, very, very difficult one to make. And it often requires, frankly, an identity shift in what does the health system need to do less of? Where do I need to shrink in order to unlock a different growth path moving forward? Said another way, it takes the realization of, where am I actually best positioned to do something in the market versus where is there a partner who might be better positioned. Maybe that partner is better positioned at doing back office support, at doing some of those rev cycle operations. That's the synthetic scale option that you see here. That's what the Optum Market Performance Partnership is. Maybe it's, we need to align across different geographies, either through kind of a classic approach, the merger, but a non-contiguous merger, or maybe it's over business model, and it's what Risent is trying to do with the creation of the acquisition between Geisinger and Kaiser, to say, how can we use our successful integrated delivery networks that work in very specific markets and try to get to benefits of scale. My favorite example here is one on the far left, between Rush and CVS, right? Rush, which is an AMC in Chicago, basically said to themselves, look, we're never going to be more convenient than CVS. The right answer for me is not to go out and build as many, akin to health hubs as I can in the Chicago area. But CVS is also never going to be able to handle the acute conditions that a Chicago AMC can. So they've partnered together, and Rush is happy to say, CVS, you be the front door. We will deal with the more complex patients. We'll deal with the more high acuity cases, and we'll do it through the ACO REACH program. But this is what I mean when I say the kinds of smart strategic partnerships that health systems are putting their bets on in 2024. Now, I want to be clear that some of those bets, smart as they may be for business purposes, may leave gaps, right? I see every day health leaders having to make very, very tough choices. I mentioned that the growth strategy for many health systems is actually to shrink in order to grow. Well, they might be making a smart decision when it comes to rationalizing services, rationalizing fixed costs, maybe even closing service lines, maybe even closing hospitals. But those are going to leave gaps for their community and for their patients. And the good news is there are other sectors that are stepping in, particularly if I think about kind of the tech space. But I want to be clear, there's only so much that those are going to be able to do. So for example, two very common areas of closure, of shrinkage, are what we see in labor and delivery and what we see when it comes to acute mental and behavioral health services. Well, if I look at the tech space, if I look at the VC space, I see a lot of investment in telebehavioral health. I kind of hate this term, but I see a lot of investment in femtech. Those are great things. I don't want to discount how great those are for patients and for communities, but an app on a phone can't deliver a baby. Telebehavioral health, wonderful for low acuity anxiety and depression, but it's not going to meet the needs of the highest risk, highest acuity patients that are really in need of something that looks like behavioral health emergency department, right? The question is, who's going to be left to fill some of these gaps, particularly as health system survival is questioned. Bottom line, we've already moved away from this hospital-centric, hospital-first kind of delivery model. And we see these ecosystems, these conglomerates really entering, I'll say, their final push for purchasing or aligning to the assets that are left in the care continuum. Health systems are seeking partnership pathways, maybe even I'll call them survival pathways, but those will only cement the shift away from them as the center of healthcare delivery. And that is going to change things like care performance standards. It's going to change power dynamics, and it will have challenges for patient access. That's just our first big shift when it comes to where care is being delivered. Now I want to talk about who's delivering that care. And maybe I want to talk about what is delivering that care. I'm going to catch myself because artificial intelligence is not sentient, but it is a combination of both who and what are enabling care delivery. And again, this is a good example of a challenge that's been happening in healthcare for some time now. But what's different and what is something I can't believe we're still talking about in January of 2024 is the combination of labor challenges that just continue and workforce shortages that just continue at the same time that we see AI absolutely exploding in popularity, right? It was November of last year, right? November of 2022 that we saw ChatGPT enter the market, right? This free access to generative AI start to change the way that we think about progress in healthcare and in all aspects of business. And I will admit that truly the lowest hanging fruit that organizations are focused on when it comes to AI is in labor. And that is because it is the biggest pain point. But I want to be clear, the tasks that tech is capable of are vast. And I also want to be clear that this trend did not start when ChatGPT entered the zeitgeist, right? If I think about the widespread adoption of just artificial intelligence, I'm not even talking about other technologies, just artificial intelligence, we see a lot of focus on certainly detection and screening, quality and risk gap detection, huge in the value-based care, the population health side of value-based payment. Even in direct treatment, medication management, another one that's important in population health and payer management. Patient education, follow-up care. These are all the widespread utilization of AI, where the widespread utilization of AI is. We're starting to see a lot of exciting trends in the emerging and the exploratory phase. It is January, which means that if you're paying attention to healthcare, you probably were also paying attention to the JP Morgan Healthcare Conference that happens the second week, kind of first week, second week of January, coming out of the new year. And something that I found particularly interesting about the conference in 2024 were two things. One, everyone was talking about AI. Everyone was talking about AI, even if they were using it incorrectly, they were talking about AI. And two is that there's still this tendency to focus on AI in general terms, which is very, very difficult for boots on the ground health leaders who need strategic direction in terms of, wait, what is this thing? What problems can it solve for me? How can I integrate it into existing operations? What's the specific next step? And so I'll say from the beginning that if we were having a conversation merely about artificial intelligence, what I would say to you is, hey, you should not actually have an AI strategy. Instead, you should think about how artificial intelligence, or frankly, any technology, any product, can help you solve a challenge that you've already identified as a top priority for your organization. Or maybe it's not a challenge, maybe it's an opportunity, maybe it's something that you want to chase down. For the context of this conversation, we're going to focus on labor because that continues to be such a pain point. But I see a note in the chat that there's interest in AI being used for population health management. If that is the top concern for your organization, for your department, for your role, think about how can I get down to the root cause problem and focus on how technology, or in this case, AI, can solve that. We are absolutely going to talk about the opportunity here, and we do believe that AI will change healthcare. But I also want to give us a little dose of reality, right? As wonderful as our ambitions may be here, we are still handcuffed to a reality that is centered around a fax machine. This is not a slide that we created from scratch. This is a real screenshot of a generative AI platform through Doximity. It's called DocsGPT. I think you can probably guess why. And this is their kind of beta use case to give to physicians in this case. I'll say in a moment that physicians aren't the only ones who can and should be utilizing AI, but to give to physicians to help them with some of their administrative tasks, with those things that are adding to burnout and decreasing efficiency in their work. And I love some of these examples. So on the top left, write a statement of support for Social Security disability for my patient with bipolar. Maybe that would take a physician an hour. Maybe it would take them 20 minutes, 10 minutes. This is going to make it take seconds. I think the example on the bottom left is really amazing, right? Write home care instructions for an 8-year-old with asthma in the style of Dr. Seuss. That may be a kind of fun example, but if you think about the opportunity that comes with personalization, the equity impact that this can have to, in seconds, be able to write home care instructions for different people with different languages, different needs, different identities, different cultural backgrounds, that's huge. My dose of reality is what you see on the right-hand side of the slide. This platform is smart. They said, hey, we know that we're doing all this work, but we want to make it easy to connect clinicians to the next step. So here you go, free fax to insurers. That statement for Social Security disability, free fax to where it needs to go next. And it is a reminder that even as individual points in the system accelerate dramatically when it comes to their innovation, when it comes to their effectiveness, the broader system needs to evolve with it for us to truly get out of our, past of not being very technologically forward. Now, I said this at the beginning, but one thing that I really want everyone in healthcare to avoid when it comes to AI is shiny object syndrome. There are, probably thousands of pitch decks of new products, new vendors that promise to magically solve problems in healthcare with their technology, with their channel. My reminder is to make sure that you're nailing the essentials. First, again, start with a specific problem or a specific opportunity. Get down to the root cause. Find the targeted technological solution for that. And make sure that you're maximizing the value of a new system that you might purchase, but even existing systems that you have, right? Clinicians have been burned plenty and plenty of times before when it comes to the promise of new technology. So please make sure you're investing in the time to make your existing systems function well, to make sure that they are solving real problems, to make basic functions as easy and effective as possible, and to prioritize the very real needs of your clinical teams, which is not just physicians. That is not to say that the burnout challenge is not very, very prominent for today's doctors, but it does mean that we can't ignore the needs of nurses. We can't ignore the needs of bedside nursing specifically. We can't ignore the needs of medical assistants, of pharmacists. We need to focus on solutions that we can implement and offer to the entire clinical workforce. I'm sorry to say that I'm not here to share the super sexy stuff when I talk about the future of healthcare here, but I will say that the leaders and the organizations that are most likely to succeed with AI aren't necessarily the ones who are, making initial investments or spending tons of money. They're the ones who are making decisions proactively about what role, what tasks does AI play? In this case, when it comes to the workforce, when it comes to labor, it's the folks that are going to make decisions that will address challenges before they crop up. Like, where will learning and training happen, right? If a lot of these tasks are going to be offloaded, made more efficient, made faster, what else do we need to put in place to ensure that learning and training happens effectively? How do we ensure that the next generation of clinicians knows how to use these technologies as effectively as possible? And one that I'm afraid is a third rail we cannot ignore is compensation. How will compensation models shift to either incentivize performance or to reflect changes in who and in what is involved in care delivery? These are very specific examples of where proactive decision-making needs to happen. Before we end this section, I'll talk about some of the higher level kind of decisions that needs to be made. I said at the outset, we focused on artificial intelligence's impact on workforce, but AI is not just going to change workforce. Y'all, we are in the flip phone era of artificial intelligence, and there's absolutely no way that if you had told me in 2004 that my flip phone can do the things that my iPhone can do for me today, I wouldn't have believed you. I could not have imagined the future state that we are today. And it's really, really important to keep ourselves grounded in that when it comes to particularly generative artificial intelligence. What we can do now is start to prepare for the future, start to prepare for the reality that there will be uneven progress among individuals and among organizations. We need to avoid the reality that merely the rich get richer, because that will only hurt health equity. That will only create more gaps in access, gaps in care that I mentioned in the last section. We need to make sure that we don't just replicate the challenges that exist when we don't use technology. And here I absolutely mean the bias that exists in care delivery. We want to make sure that those biases don't trickle from the physical world into the virtual world. And we need to be mindful of how power levers are changing. Will we become more reliant on a handful of vendors, on tech ecosystems, to again borrow a word from our first section, or will suddenly our partnerships and our opportunities be spread out across dozens, hundreds of vendors because so many different opportunities are cropping up, right? We have to watch for these potential consequences and plan against them as AI becomes more prevalent, more powerful, and frankly, as it becomes less expensive in healthcare. So we're moving from this world of the overextended generalist into one of tech-enabled top of license care. This is actually one where, and I want to be clear here, I never said this, but I want to be clear. Tech is not going to replace humans. But we could be driving towards a future where in some cases, in appropriate cases, clinicians are the complement to technology rather than the other way around. That's what can happen if I kind of completely roll the tape forward. That new era of tech enablement, right, of that efficiency, it's going to open a lot of doors for our business, but it could also entrench some of our biggest challenges and shift control and power dynamics over who has control over care decisions. And those are things that today's leaders need to be mindful of and frankly, harness if they want to change moving forward. Now, I saved the biggest one for last. And if I reflect on where we've been so far, I kind of think about it this way. So in our first trend of where care is delivered, that's probably the one that I'm guessing that all of you kind of knew the most about coming into this conversation, right? The trend away from hospitals towards ecosystems. Maybe you called them something else. Maybe you called them payviders. Maybe you called them vertically integrated ecosystems. Maybe you called them platforms. That was our first area. The second one on AI and care teams, this is one where, to be frank, I think folks think they know a lot of what's happening, but there's still a lot of correction and nuance and direction that I'm offering to today's executives, particularly out of the clouds and into the minutia, which is actually where they need to be. This last one, this is the one that I really fear we're the most unprepared for as an entire industry. And this is the change in what the definition of care even is, and certainly how we pay for it. And I believe that we're going to move from a world where our healthcare business is defined and frankly economically supported by procedures to one that's defined by bespoke care. Now, what do I mean by bespoke care? I mean this rise, this new era of ultra personalized, very, very expensive products that will change the course and trajectory of a patient's outcomes. I mostly mean the rise of breakthrough drugs, but this can also include other kinds of clinical products, particularly when I think about diagnostics, devices, and the like. But for the purposes of this conversation, I'm going to mostly talk about drugs. So let's think about where we are in today, right? January 2024. The innovation that's happening on procedure side is about fewer procedures. It's about less expensive procedures. It's about procedures that are done in more outpatient settings. The innovation on the drug side is novel products that address diseases that don't have good outcomes, products that address diseases with no other treatment. And again, because of the truly exceptional, wonderful work that science has done, we have access to these drugs, these breakthrough drugs, all of which are incredibly expensive. So it is no wonder that I'm having conversations. This data on the bottom left-hand side came from a real conversation from I will say a retiring health plan CFO who said, my drug costs are equal to my hospital operating costs right now. And I'll tell you, that was at the end of 2022, right? So it's only getting worse, getting harder to manage. Now, I've said the word drug several times, and I know that there's a specific class of drugs that you want to talk about. And that is, of course, the weight management drugs, which have driven frenzy in our business and in our country, in our communities, among our populations. I want to be very, very clear that for the purposes of this conversation, I am only going to talk about the weight management drugs for their on-label use, for the FDA criteria, right? And the onset of these drugs really has come out of the fact that the obesity epidemic continues to be a challenge in the United States in particular. The chronic conditions related to obesity are huge drivers in terms of outcomes, in terms of spend. And there is no kind of single solution or easy solution to obesity, even with lifestyle changes, behavioral changes, et cetera. It's this kind of web of challenges. And so we see, and I want to be clear, drugs that addressed obesity existed before this last year, but the big kind of landmark change is in what we saw with semaglutide, right? And the GLP-1s. Important because huge populations, 142 million people in the United States alone, are eligible for a semaglutide according to the FDA criteria alone. Huge population is eligible. Huge population wants it. 44% of people with obesity would change their job in order to get coverage for obesity treatment. Now, huge population for a drug that's pretty expensive. I mean, the sticker price, which the sticker price isn't the ultimate purchaser price, but the sticker price is what, $1,300 a month? No wonder we see complete variation in coverage. There's this new rise of direct-to-consumer companies like Ro and Weight Watchers that have tried to enter the weight loss medication space and directly sell to consumers. We see health plans taking kind of variable approaches to who do they cover these drugs for and what. A lot of them are raising the bar and saying, it's actually, we're going to make it more than the FDA criteria. That's the same thing that we're seeing in the employer space as well. As of right now, Medicare is not covering weight management drugs. You better believe that is why all the pharmaceutical companies are so focused on clinical trials that show that these drugs don't just influence body size, but also influence your metabolic panel, right? The November Select trial results, how they influence cardiovascular outcomes. There are studies on its influence on Alzheimer's and depression and anxiety and so on and so forth, to try to force purchasers, health plans, employers to cover the costs of these drugs. And that is just one example. And it's important to remember that not all high-cost drugs are the same. We talked about GLP-1s, big population, smaller in context price, although, still a very, very substantive price. And the clinical significance are huge. They are immediate, but they go away when you stop taking the drug. So we're talking about a very, very long timeline for utilizing these drugs, even when other interventions are included, like lifestyle interventions, right? So the cost of that class of drug alone is quite high, even though the variables are different. Now let me compare that to a class of drug I'm not sure that you've heard of, which is called cell and gene therapy. Right here, the example is CAR T cell therapies. These are often one-time treatments. The cost isn't $1,300, it's $2 million. One-time treatment, very, very specific administration and logistics that only a handful of players can do across the country. But here we're talking about a cure. Here we're talking about a patient with a rare disease that will live a relatively normal, long life because of the onset of this class of drugs. That's what I mean when I say that science has done its job. The challenge is what that means for all of the other players in healthcare. Who is going to feel the benefits of the improving outcomes and the decreasing healthcare costs of a drug that's administered to a baby, let's say, right? That will, in the case of cell and gene therapy, that will save their life, for all intents and purposes, cure their disease. But think about all of the payers that are going to take on the cost of care for that patient long term. Only one of those is going to spend the $1 to $2 million up front. Are they going to seek the benefits long term? That's the question that a lot of payers are asking. Same thing when it comes to the weight loss drugs. So really what I'm saying is that as we move away from traditional procedures to these bespoke therapies, it is going to change a lot of the business characteristics that maybe I'll say we've taken for granted in healthcare, right? How we deliver the innovation, how we define access to care, the kinds of wraparound support that is necessary to succeed, certainly what cost and quality looks like and what its management looks like, and how we finance these drugs. So what are purchasers doing? Frankly, they're returning to old tools. They're focusing on what do we cover, who do we cover it for, and no more. In fact, we see a lot of restrictions. We see a lot of carve-outs, particularly for those ultra high cost drugs like cell and gene therapy. I'll say that over the last few years, the focus on innovation in healthcare has largely been on these new novel bespoke products. The next era of innovation has to be on alternative models to manage cost. I started off this conversation by saying that by our own metrics on value-based care, we are not succeeding on quality and spend. Well, our strategy to perform in value-based care effectively has also largely ignored the drug space and has focused on the procedure space, and that will require alternative models. There are some examples that people are using now. Stop-loss insurance is the most common. Outcomes-based agreements are a lot better. They're really hard to execute or to get all sides to agree on, let's just say. So what we're left with in the near term is a lot of experimentation and frankly, a lot of fragmentation, a lot of variability. And those dynamics are only going to intensify our usual challenges. I'm very concerned about two-tiered access. I'm certainly concerned about hurdles to payment transformation and what it is going to mean for ultimate patient outcomes. this is perhaps the biggest change that I want to make sure everyone in healthcare, and in particular CEOs, are focused on when they think about their plans for 2024, for 2030, for 2040, because our healthcare business is transforming to one that will be defined by an era of bespoke care and high-cost drugs. I don't mean to spark fear in anyone. In fact, what I hope I can do and leave you all with is actually some urgency to respond, and frankly, the responsibility that everyone in healthcare is going to have in order to succeed moving forward, in order to define what success looks like across the future of healthcare. So if I think about the three changes that we've been talking about, where care is delivered, who is delivering it, what that care is, and how we pay for it, the practical next steps, the responsibilities of players in healthcare is to figure out what are the standards that we priority? What are the service offerings that we need to make sure are pervasive across healthcare? That's really going to be the focus for employers and for digital health. There are going to be players that need to expand and track care coordination and make sure they're managing patients longitudinally, even if our system becomes more complex, maybe even more fragmented, right? Across different power levers. That's going to be a big focus area for plans and for medical groups. And there is real responsibility to protecting access. Protecting access to physical sites of care is likely something that's going to fall on hospitals and health systems. And protecting access to novel breakthrough therapeutics is absolutely something that I'm going to be looking to life sciences companies to do, as they've, been instrumental in the creation of a lot of these novel products. Now, we could spend so much time about these paradigm shifts that are happening in healthcare. What I want you to hear is that these are not things that might happen in the future that you may need to react to. These are things that are happening now. In fact, they are accelerating now. And we need to both anticipate what the future could look like and frankly, embrace our responsibility moving forward. If you want to find more information about this, there's lots of ways to do this. I realize that you might feel like you've been drinking from a fire hose across this hour. First, I want to say that Advisory Board, this is a wonderful, great picture of me, has a podcast called Radio Advisory. Episodes come out every Tuesday. Go ahead and pull out your phone, use this QR code to download and subscribe to Radio Advisory. The episode that dropped today and the episode that dropped last Tuesday are actually all about the forces that I mentioned today. So we spend one entire episode talking about this moment of instability, what purchasers are doing, and changes in where care is delivered. The episode today dives into changes in technology and care teams and bespoke care and the rise of high-cost drugs. So please download and listen to those episodes, share them with your colleagues and your friends. Easy ways to keep up with what's happening in healthcare. You can also connect with me at Vive 2024. I am going to be hosting a panel that's actually all about labor and all about how technology can really help reinforce a lot of the longstanding goals that clinicians of all stripes have while alleviating the administrative burden of medicine. That's going to be on Tuesday, February 27th. Come find me, say hi. I'm always excited to rub shoulders with people and to talk about the future of healthcare. I also want to say, for participating, here's another QR code. You can use this QR code to download the full briefing, the full research material that we have on what CEOs need to know in 2024. If it's not listening to the podcast, this is going to be your physical kind of reading way to keep up with what's happening in healthcare and how we're advising healthcare executives. Now, that was quite a bit. Advisory Board exists to help you in many different ways, both understanding what's happening in healthcare, navigating your own organization forward, and making sure that you have what you need to make better decisions moving forward. With that, I want to thank you so much for your time and good luck with your strategic plans in 2024 and beyond.
Thank you to Rachel and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Los Angeles, February 25th through 28th for Vive 2024.